Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and welcome to Attitude Magazine's ADHD Experts broadcast. We are pleased to have Dr. Benjamin Yerys here to talk about diagnosing and treating ADHD and autism in adults. Before we get started, let me note a couple of housekeeping items. Those of you tuned into the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you are interested in the Certificate of Attendance option, look for instructions in the email you'll receive around an hour after the live broadcast. For those of you listening in replay or podcast mode, you can visit attitudemag.com and search podcast 354 to access the slides, the webinar replay, and the Certificate of Attendance option. And just wanted to say, if you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine for your family or to share with a teacher or a loved one who could benefit from greater understanding of ADHD. And also, the sponsor of this week's Attitude webinar is Accentrate, a dietary supplement specifically formulated to address the nutritional deficiencies known to be associated with ADHD. Accentrate contains the omega-3 fatty acids, EPA, and DHA in the phospholipid form, which has been shown to be the preferred carrier to the brain over other fish oils. The brain-ready nutrition provided in Accentrate works 24/7 to help the body even while sleeping. For more information, go to www.accentrate.com. And finally, Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. Now for today's topic. ADHD is one of the most common co-occurring conditions for individuals on the autism spectrum. Adults with ADHD and ASD diagnoses experience a poorer quality of life and less developed communication and social skills than those with ASD alone. Surprisingly, almost all that we know about the intersection of ADHD and ASD comes from studies with children. What about adults, though? Many questions center around that. Does ADHD persist into adulthood for adults on the autism spectrum? How do clinicians tease apart these diagnoses? Are adults diagnosed with ASD affected by ADHD in the same ways as children? And what can we do to support adults who have both diagnoses? Dr. Yerys is a licensed psychologist in the Center for Autism Research at the Children's Hospital of Philadelphia and an assistant professor in the Department of Psychiatry at the Perelman School of Medicine, University of Pennsylvania. Dr. Yerys leads the center's research on the brain basis and treatment of attention and executive function. He has published extensively on the presence of executive function impairments in children with ASD and how they relate to core repetitive behavior symptoms of ASD or common co-occurring disorders like ADHD. You can ask questions during Dr. Yerys' presentation, and we will get to as many of them as possible after he finishes. So with all that being said, I'll turn it over to Dr. Yerys. Thanks so much for being here today.
Thank you. Thank you so much, Wayne and Attitude for inviting me. So just to get started, I'd just like to show conflicts of interest. These are, some funding sponsors of research I'm involved in. And I just want to say that none of it will sort of impact or be related to anything that I'll talk about today. So I thought it would be important to maybe start with talking about the formal diagnostic criteria for autism spectrum disorder, because I think it's not as clear what we look for when we're doing an evaluation, and particularly so in adults. So there are sort of two major domains of behaviors that we look at when we're trying to make a decision if someone is on the autism spectrum or not. The The first domain is sort of what we refer to as the social communication and interaction domain. There are 3 areas of behaviors that we're evaluating. And when we're doing an evaluation, we will look for different things depending on the age. So my expectation of the kinds of, reciprocal or social emotional reciprocity differences will be different in a 3-year-old than when I'm working with a 23-year-old. And the same goes for thinking about nonverbal communication or looking at how they go about developing or maintaining relationships. And so the key thing I will just say is reciprocity, just to define that for people, is really about having like that sort of natural back and forth with another person. So when you're having a conversation or you're engaged in play or some kind of interaction, there's usually some sort of to and fro of one person doing or saying something and then the other person building upon that and then building and then building. And sort of understanding how people are able to navigate that while sort of participating in the interaction is sort of what we will do or what we look for in reciprocity. Nonverbal communication is another way of saying body language. So this is where we often talk about eye contact in autism. We evaluate that under nonverbal communication, but we also look at how people use gestures or their body to communicate. There's different types of gestures we use. Some can just be beat, like emphasizing a point. And others can have an actual function. Like if you're talking about a time you went on a roller coaster and you're doing this, that would be more of a descriptive gesture. So we evaluate how people would use those in their communication style, along with facial expressions, being able to make them, but also understand facial expressions in others, tone of voice, just lots of sort of social cues or body language that sort of helps support what we're trying to communicate to somebody else. And the last area is looking at developing and maintaining relationships. And so this is really a lot about understanding how people go about building a friendship. Do they have a best friend? Do they seem even-footed? Do people sort of maintain a friendship and sort of take turns in friendships? Sometimes when you're interacting with someone, maybe you do an activity that you prefer or an activity that your friend prefers, and just sort of seeing how people navigate that. And that's sort of a lot of what we look at in that particular domain. And then the second set of symptoms or behaviors that we look at is I'm calling shorthanded repetitive behaviors. There's a much longer title, but this is just easier. And this is looking for behaviors, interests, activities, routines, or even rituals that people really want to maintain, every day or over time. And there are 4 categories that we look for, but there are only 2 that are required in order to make a diagnosis. And so one is movement or speech or object use is highly repetitive. So in terms of movement, this might be hand flapping or another kind of finger movement that is very repetitive. It may be something that's more whole body, like pacing in a set way around your house, maybe touching certain parts of your house. It may also be repetitive in terms of speech, maybe starting conversations the same way, having some odd or unusual ways of saying something, maybe coming up with your own ways of describing something that already has a name. And then also repetitive use of objects or everyday routines. So this might be lining up toys rather than actually playing with them. This might be just sort of repeatedly turning a light switch on and off, or opening a car door on, open and shut, or doing some other sort of repetitive routine with an object. Need for sameness is a shorthand way of talking about routines and rituals, of just wanting things to be exactly the same day after day on the same schedule, and really having a lot of difficulty if those things are changed, or struggling with transitions or unexpected changes in your environment. When I think about people trying to manage, roads being closed, having to take a different way home, how much does that sort of disrupt your day-to-day activity? How much distress do you experience by having to do something differently than what you've expected? This is a lot of what's captured under need for sameness, as well as what I might call cognitive rigidity. Cognitive rigidity is the idea that you just sort of see things in one way, and it's really almost like black and white thinking. And it can be really hard to see the way other alternatives are, seeing gray between 2 choices. And then interest is something that often is shown a lot in autism. When you see sort of stereotypical presentations of it, might be showing that people on the autism spectrum really enjoy trains or train schedules. But in reality, these interests are far broader than that. And they can be age appropriate. There are many adults that enjoy reading about the Civil War, but for adult on the autism spectrum, their interest in their intensity level of how much they talk about it or read about it is far greater than it would be for other people. And rather than being a point of maybe something that you might share with others or really bring that together, it may be something that actually pulls you away from social interactions or gets in the way of, getting other things done. And that's one of the things that we examine, because everybody has interests, everybody has hobbies, and people can be very passionate about it. I live in the city of Philadelphia. There are a lot of people that are very passionate about the Philadelphia Eagles. And so I would really not want to say just being passionate about something by itself makes it a special interest. It's really about trying to understand how it may get in the way of function for some people. And then finally, there's sensory sensitivities. And this was just added in the last change to our diagnostic manual, which was in 2015. And this is really speaking to the fact that many individuals on the autism spectrum identify as having a lot of unusually strong responses to sensory information. So this can be things like, certain sounds that would be everyday sounds for many people, but would be particularly bothersome for people on spectrum. Vacuum cleaner sounds, or I've even had one child to discuss a bread maker sound. Just the ding was really irritating. It was like nails on a chalkboard. So we often hear about those sensitivities, and they can go in two directions. They can go either, people really want to avoid those sensory experiences because they find them aversive, or just it's too intense of a sound or a taste or a texture, or it could be something that's really appealing and they want to have more experience of it. So wanting touch, but only wanting a deep pressure hug rather than sort of a light feathery touch that doesn't feel very good or positive. And then other experiences as well. So those go under sensory sensitivities. And that, again, only 2 of 4 need to be present to make a diagnosis. So the other sort of key things we keep in mind is that behaviors must be present during development. They really have to cause significant impairment in functioning, and that's really true for any diagnosis that's made. And the other thing that exists in the DSM-5 criteria, which is really important when you think about adulthood, which is if anybody had a diagnosis under the DSM-4, it carried forward to DSM-5 automatically, even if their current symptoms or behaviors didn't really meet the DSM-5 list. Because previously you didn't need 2 symptoms of repetitive behaviors, you only needed 1 to have a diagnosis of autism, but you needed 6 total, and there were 3 categories because we split social interaction from social communication. Those were 2 separate domains. So anyway, this is just a long way of saying that we didn't want to discount people who had a diagnosis, were receiving services and supports, and then they lose it because the criteria have been adjusted to some degree. So that's definitely something when I'm working with adults, and then I do work sometimes with young adults up to about age 25, where maybe they got a diagnosis of pervasive developmental disorder, which was something that existed under DSM-4, but now under DSM-5, everything that was related to the autism spectrum was sort of eliminated. So no autism, no Asperger's, no pervasive developmental disorder. All of them were replaced with just autism spectrum disorder. And so this was to sort of allow people to still have that diagnosis and to continue to get services. So I definitely think about that for people who are older and coming in and maybe have that diagnostic history. There are also what we call specifiers. These are other conditions that may occur alongside autism spectrum disorder, but not for everybody. And so we're supposed to evaluate that as well. So one of these is looking at intellectual disability, which for those of you that are I'm in my mid-40s, so for a lot of people I talk who are in that age range, remember the diagnosis of mental retardation, and intellectual disability has now replaced that name, or that's what we're using now. And then language impairment is also something we evaluate because it's pretty common. Intellectual disability is about 30% of the autism population. I think language impairment is maybe a little bit higher. And that's just sort of a delayed onset, either of spoken language or having some difficulties with understanding other people's sort of language towards them, sort of receptive language. So those are 2 things that we look for because they happen enough that we need to sort of be mindful of them as additional diagnoses. associated with a known medical genetic condition. Sometimes this is also referred to as a syndromic form of autism. This is when there may be a genetic condition that often, when it happens, there's just a higher rate of autism. So Fragile X is a really common one, where, depending on what study you look at, 25 to 50% of people that have Fragile X variant in their genes, particularly males, they will also meet criteria for autism. And so that's just something we like to specify so people understand that. When we make the diagnosis, the last thing that I'll say here, because I want to make sure I get to everything, is we really are also supposed to acknowledge the level of support that's needed. And this is not quite the same as saying severity, but I think it's how a lot of people think about it. And it's really supposed to be about what supports does a person need. And I tried to give examples which are taken directly from the diagnostic manual for what you might see in the social domain versus the repetitive behavior domain. And so a lot of adults, when I'm seeing people in their, early adulthood, which is what I see, or people that are thinking about it in later stages, they tend to fall under this stage 1 or level 1, which is requires support, because people have been able to get along fairly well with some challenges, but still sort of, continue to progress in life. And so, here a level 1 is, without supports, impairments may be noticeable in either interactions, or people might see inflexibility in this situation. They may have some problems with organization and planning. And so there's some sort of acknowledgement that there's some challenges there with no supports. And with supports, people may still have challenges, but some people, when they get those supports in place, they do exceptionally well. And many people may miss that someone is on the spectrum. Which is, again, our goal as a clinician is always to help people, live their best life, reach their highest potential. And so, that's great if people get there. And one thing I just want to highlight here was sort of the acknowledgement of problems with organization and independence as being a really critical feature, and partly because of how it may overlap with ADHD. Just a comment on prevalence real fast. So the current rate of autism is estimated at 1 in 54, and all of our research, it's done on 8-year-olds. This is what the Center for Disease Control, the CDC, has decided is the best way to evaluate sort of national prevalence rates. Our most recent rating, which is data taken from 2016, it's always a couple years behind, they actually found that in 2016, it was the first time there were no differences in diagnosis between Black and white children. That basically there had long been sort of this equity difference across where Black children were identified at later ages or not at the same rate, even though a lot of our genetic research and our biological research suggests that there shouldn't be a difference across race or ethnicity. So that was really nice to see from a screening standpoint, although Hispanic youth are still identified at a lower rate than both white and Black children. 4 out of 5 ASD diagnoses are in males. There's a lot of questions about whether that's accurate, whether we are missing females, because a lot of our diagnostic tools were developed with males in mind, because that was the predominant gender that was identified. And so that maybe we don't identify enough females. And so there's lots of research asking that question. And about a third of people, I think I mentioned this before, will also receive an ID diagnosis. When we talk about the intersection of autism and ADHD, I think it really depends, like how often does ADHD occur in the context of autism? It really varies depending on where you look. So there's very little research in adults. I could only find 2 studies at all outside of what I'll present today that will talk about ADHD in adulthood for people on the spectrum. And these studies basically had a rate of around 20 to 37% of their sample, which they were recruiting for autism and ADHD studies in adults. They met criteria for ADHD. When you look at the pediatric literature, if you look in clinics, almost 3/4 to 80% of kids that come into a clinic looking for sort of diagnostic help will have an autism and ADHD diagnosis, which is very, very high. But families are coming in because they have a lot of concerns about how their child's progressing in school or with friends. when we look at research studies where we're not recruiting specifically, for ADHD, or, these aren't families that are looking for support immediately, the rates that we are identifying is anywhere from 30 to 65%. And then there's sort of one very nice study out of the UK. It's probably about almost 15 years old now. And they did a population-based sample just across the UK population, sort of getting everybody to fill out information. And then they identified their population rate of autism and then their population rate of ADHD in that population. And it was about 30%. So when you really sort of take that biggest scope of trying to get everybody, it ends up being around 30%. So what prompts a referral? I said before, there's different things that prompt a referral. When we think about adulthood, the most common things that tend to come up is people having difficulty with work or relationships. Sometimes a failure to launch will be a big sort of driving motivator to come in for a referral. And then also, and I'm seeing this now a lot with social media, people seeing something about autism and seeing similarities between themselves and others. And I have to say, I've seen actually a fair number of females on the autism spectrum during the pandemic who are home and spending a little bit more time on TikTok or other social media outlets, and sort of realizing that experiences they're having are being reflected in social media. So there's at least one good thing that's coming out of it is they understand that, and they say they don't feel alone, but then they really do want a diagnosis. And so that's been an interesting experience for me as a clinician. When we look at the criteria across autism and ADHD, I'm not sure that this is really legible, but I tried to just get it on one page. When you think about sort of the social communication, the social interaction difficulties I talked about, the repetitive behaviors, you might say there's really not a lot of that sounds a lot like ADHD, like making a careless mistake, or maybe losing things, or being distracted, or not being able to sort of be feeling restless, or feeling like I just never quite get things done. I'm always on the go. And so you might say, why would there be any difficulty sort of teasing these things apart? Well, a lot of these behaviors, and I just highlighted a few from research I've done in children, where there were a number of some of these items that they did sort of get over-endorsed by people by parents of kids on the autism spectrum, because I think there's really a really strong social component to the questions, to the symptoms of ADHD, because we ask questions like, does this individual listen when spoken to directly? If they're, that they may not be listening because they're distracted, and that might be more an indicator of ADHD, or they may not look like they're listening because if they're on the autism spectrum, they may not enjoy eye contact and may not give you eye contact. And so it's not about not listening, but it's about being able to participate in an interaction in a way that's comfortable. And so a rater might say, rating that, endorsing that item, but it's not really about ADHD. It's maybe more of an autism reason. So there are reasons to think that there could be some sort of difficulty trying to tease some of these things apart, that you may see elevations for both conditions, but they may be very different reasons why someone may be elevated on a particular question. When I'm doing an assessment for ASD and ADHD, I want to say we, but I can't speak for every provider, and I want to be clear about that, is that, people, other clinicians may have a different viewpoint on this. As of right now, there is no gold standard diagnostic practice for teasing apart autism and ADHD in adulthood. We're barely just getting there in childhood. And so I will say what I do in trying to be mindful of the person's experience who's across from me and trying to understand what's going on. So one is, there is no single test that discriminates the two. Both diagnoses are based on behaviors that unfold over development. It's not like one day you wake up on your third birthday and there's all the symptoms of autism, and so we can make a diagnosis. These are things that happen across time. Same thing for ADHD, because there's an early age where you can't really see activity differences, because at 2 or 2.5, a lot of 2-year-olds are all over the place and they can't pay attention for very long. It's really hard to understand those differences at very early ages. So it really is about unfolding over time. And so what it's really about is trying to the best that you can. And when I'm with adult, obviously going back to early ages, whether it's getting access to someone that really saw that person at that age or saw that person and remembers well, it can be really trying. And so it's really about trying to do the best you can of piecing things together, of where the challenge is coming from. And sometimes that is really hard. And sometimes I can't make a clear call. And I'm honest about that. I don't know if all clinicians feel comfortable saying that, but the goal for me at that point is really focused on treatment and what's going to support you as an adult. How can I help you, achieve the goals that you want? And a diagnosis is a way to get you on that path. So I'll talk about that. And that's just one way that I go about it. But certainly I hope other clinicians do that as well. But there are some gold standard tools that we use. And so I do want to talk about a couple of those. So for ASD evaluations, getting a detailed developmental history when possible is great. It's really helpful for teasing some things apart to understand how things unfolded across development and what may be new or may be driven by there was some major life change, and as opposed to something that was sort of always there and just sort of seemed to sort of grow and develop as a challenge. In terms of autism screening tools, I would say when I can get a good rater, I like using the social communication questionnaire. It's got really nice discrimination. For adults that don't have that reporter, a lot of people like using the autism quotient or the autism spectrum quotient. If you hear either one of those, the AQ for short, it's the same thing. And there are pros and cons. I've definitely heard autistic individuals say that they really don't like the way some of the questions are worded. It doesn't capture their experience. I think that's all very fair. But it is still, it's sort of the best of what we have, but it could still be better. And I think the people who created it understand that and continue to try to, revise and improve. This measure that I'm going to highlight next, the Autism Diagnostic Observation Schedule, sometimes referred to as the ADOS, is a very good sort of clinical interview that's really targeting not only trying to understand people's experience, but also trying to observe and log people's nonverbal communication and other social skills. And that's, for the most part, our gold standard for what we use in childhood. It's been very challenging in the time of COVID because we have to wear masks. So being able to see how a person reacts to my facial expressions, how they're using their facial expressions when they talk is very difficult. And so we're not really using that right now. And what I will say is, while it performs very well in children, we have seen it's pretty good in adulthood, but it's not amazing. And so you really have to bring in these other pieces of information, including adaptive behavior assessments, which is like a measure of one's activities of daily living and their independence. And then the other thing I will also include is a targeted psychiatric assessment, because whenever you're looking at autism versus something else, you really have to sort of sweep all corners of the room and make sure you're thinking carefully about what's driving that behavior. That's really the goal, is if you're going to say something is related to autism, you're also saying it's not related to something else, because otherwise you're just sort of double counting multiple behaviors and it doesn't make sense. So I just want to comment on adaptive behavior because it is important for the evaluation and for the research I'll show. It can be done by interview or by questionnaire, and it's really about not what can you do, but what do you do in your day-to-day life. And this is really a driving measure right now for also understanding intellectual disability. There are three major domains that are covered: are conceptual skills, which includes ability to communicate or ability to sit down and listen to lectures or informational talks. Daily living skills is another way of saying activities of daily living, hygiene, healthcare, being able to take care of an apartment, being able to take care of your finances, food for yourself. All of those skills fall under daily living skills. And then socialization, which is understanding general and using general, like socially expected norms, developing hobbies, coping skills when you're getting frustrated, or how you manage yourself and your emotions. All of that is under socialization. And so we look at those as well, because a lot of times, particularly for people that are bright and on the autism spectrum, we see that those skills can lag quite a bit from somebody's general intelligence, and maybe a bigger barrier to living independently or having a job than any autism symptom. And so that really becomes an area of major focus for me when I think about adulthood. In the psychiatric assessment, the most common things I'm sort of crossing over between autism and something else, I'm looking at social anxiety or social phobia, which is really that fear of being around new people or a lot of worry about what others might think about you. And that may cause someone to withdraw and not participate in social interactions. But that's different from sort of having challenges or weaknesses in understanding what other people's facial expressions mean, or understanding how other people might be thinking or feeling. But that, sort of having a hard time understanding that, that's more of on the spectrum as opposed to social anxiety, which is more being fearful of that person's evaluation of you, what they think of you. Generalized anxiety is just another form of anxiety that's just anxiety about everything, the future, how things work out for me. Do I do as well as other people? Obviously, ADHD, as I mentioned before, there are quite a bit of pieces of elevated symptoms in ADHD that cross over for people on spectrum. So I definitely want to think about that. And I think a lot about, for ADHD, I think a lot about how often do those ADHD symptoms occur in non-social situations. And that will often be my key conversation point for families and adults, is to talk about, do you feel distracted even when you're working alone? And is it truly distraction to something, unrelated, off topic, daydreaming, or is it are you being pulled into, like, you're supposed to be doing your work, but you start, thinking about a sound that you hear, you're very sensitive to sounds, and that's bothering you, and you want to figure out, where does that sound come from? I would not necessarily think about that as an ADHD symptom. I would think about that as a sensory sensitivity. And so I really want to be mindful and sort of evaluating, when does this sort of inattentive or impulsive behavior come up? And can I really localize it to not being related to autism, not happening in social situations? I think a lot about OCD as well, because of the rituals and sort of the rigidity that we talked about under repetitive behaviors, that has a lot of intersection with OCD. So I think about that as well. Very rare differentials. And usually there's much more complicated history involved, but sometimes something on like a schizotypal or schizoaffective can come up. Sometimes bipolar with psychotic features. There'll be crossovers. And honestly, more times than not, I tend to be seeing people who they have had those diagnoses, those severe mood and psychiatric diagnoses, and somebody's come to me and said, well, is it autism instead? Have we just missed the boat? It's very rare that that's happened, but it's a question that people come up because they might see certain, behaviors that occur, and then they say, well, that routine looks like something I've seen in autism. And just because you have a routine or do something in one way, that does by itself mean that you may be on the autism spectrum. But certainly it's worth, a second pair of eyes. As Wayne said at the beginning, and I do apologize if I'm talking fast. I'm a New Yorker by birth, and it happens. So I apologize. But I've done a lot of work, and others have done a lot of work trying to understand for children if there are any additional challenges for kids when they have a second diagnosis of ADHD, or just the two together. And we've done some nice work, and we've highlighted that in particular for these adaptive behaviors, these sort of daily independent behaviors, we've identified that ADHD, and I don't know if you can see me and my cursor circling the ADHD box in this sort of picture here, but ADHD symptoms do seem to provide sort of an added risk, or kids that have those symptoms tend to have more problems with their independence, with their activities of daily living in particular. These other boxes that are here talking about age, talking about IQ, talking about autistic features or behaviors, those all have some influence on someone's independence. But even after you account for all of that, ADHD adds something unique. And so I really believe that providing supports for ADHD symptoms, may also make it easier to sort of help kids build on those independence skills, those life skills. The other area that's been examined, not by me personally before, but I will show you now some new work, but people have looked at it in a very large network of over 2,000 individuals from ages 2 to 21, looking at how ADHD might influence quality of life. And they looked at a number of domains. In that original study, they looked at physical health, they looked at social relationships, they looked at psychological health, which is like how much stress does the person feel. And in those domains, they found that kids or young adults up through young adults because they went to 21, they did experience that if they had a second diagnosis of ADHD, they did have lower ratings of quality of life, that they were having more distress and, sort of psychological health problems, more problems in social relationships, more problems in physical health, more academic problems. And so that was really notable. But to date, no one has really looked at these questions in adulthood. And as I was telling Wayne and as a member of his staff before this talk, I have a colleague who does a lot of work with adults, and we've worked together for 15 years, but I've never collaborated with him in studying adults. But this was something that we were very interested in because I had written a book chapter highlighting all the research on ADHD and autism. And when I got to adulthood, there was just kind of a black hole of information. We just didn't really have an understanding. So we did a first pass study. There's a large autism network called SPARK, and it's funded by the Simons Foundation for Autism Research. And it's about bringing together, individuals, families that are on the autism spectrum, collecting genetic data, because they believe the future is going to be that there isn't one autism, there are many autisms, driven by different combinations of environmental factors, genetic factors, and they want to be able to have a large community of people that would be interested in understanding research, interested when new treatments may become available for specific, sort of gene-targeted therapy or other ways that they're thinking about novel treatments or supports, to sort of come together to be able to have that available and to be able to participate. So from this, we had a total sample of 724 adults that participated. They had a mean age of 40, and you can see a very wide age range of 18 to 83. More than half were actually females. And these are all people that had a diagnosis from a qualified professional, psychologist, psychiatrist, a developmental pediatrician when they were younger, a neurologist. And as you can see, we used the autism quotient as our measure. 688 met criteria for the ASD cutoff, and a subset did not. But we looked at this, and I really wanted to know if I measure autism traits or features and ADHD, and I try to measure it like as a dimensional, not just yes, no, but just here's the behavior. Does this happen for you? And how often do you see that problem or that challenge? Getting that as a dimensional rating, then I could start to see, is there sort of like this increasing effect that as the ADHD symptoms are rated as more challenging, more impairing for you, does that lead to more difficulties? And so we sort of did the same thing we did before with adaptive behavior, but because we really found our best signal or our best information for those activities of daily living, that's what we really focused on in adults. And we've heard from autistic adults saying, that's something I really care about. Like, I want supports for that. I want to live independently. So all the control variables that I talked about before that we know relate to these skills, age, IQ, autism traits, things like socioeconomic status, we wanted to account for those things, an active depression or anxiety diagnosis. We controlled for all of that. And then on top of that, we then looked at ADHD afterwards. And what we found was that we were able to explain about 5% more of that variance, that was adding something new. 5% might feel small or little, but generally speaking, this is about what we see in when we think about some kind of skill or a condition like ADHD, sort of predicting or explaining something else. This is about the way what we see when something's actually pretty meaningful. So this was really encouraging because this is what we had seen in childhood, and now we're showing it's still there in adulthood. And that seems very important to sort of understand and maybe think about for future research of something to impart on. We looked at the same thing for ADHD on quality of life across all of those domains I mentioned before. So physical health, psychological health, environmental health, which is sort of how you think about, where you're living, and your satisfaction with that, and the money you have and the money you're earning, what's your satisfaction with that sort of environment that's around you. And then the last one is a autism-specific quality of life questionnaire that was developed in sort of a combined collaborative team of researchers along with people on spectrum to try to identify what would be the things that are really important to people on the spectrum, that autism quality of life. And all of that there, we got rates between 1% and 7% So, some of them are pretty small, but still meaningful. That 7% was the relationship to psychological health or quality of life. And that really makes sense, that's what ADHD is closest to is psychological health. So in terms of experiencing like distress about how you feel or how you feel about yourself, that sort of makes sense there, that sort of satisfaction. So that was really important. So just to summarize this takeaway, ADHD symptoms are associated with a lot of greater difficulty or functional impairments. And also that raises the question about treatments. I had a few more slides, which obviously you can sort of go through over time. I'm seeing I do want to leave time for questions. I want to be really clear up front that there is no study that is using ADHD treatments with adults on spectrum. That does not exist right now. And so everything that I talk about or that I do, or that even from this upcoming paper here, all of this is based on trying to adapt what we know has worked and has been shown to be successful in kids on spectrum, and now trying to use them with adults. And this paper, which just came out last year, was the first time that I had even seen clinicians just getting together and just trying to come up with what do they agree on? What's their consensus of things that can be helpful? And so that was really new and nice. And I loved how they broke things out by different domains of life. So emphasizing the things that, when you talk to the adults that you're working with, they say they care about. So when we think about supporting adults for education, or so thinking about college, that level of education and or job training and just getting a job, this is the vocation side on the left, where we're talking about identifying realistic career goals, volunteer opportunities so people can learn what a work environment looks like, support for completing applications and sort of coaching through job interviews, understanding if employers are going to provide neurodiversity training, because it's really a two-way street. And I think that's something that the autistic community has been saying a lot for a long time, that they're doing a lot of work, but that we as neurotypicals need to also do our fair share of work to be supportive for them. And that's a very fair and beyond reasonable. I mean, it needs to be done. And then reasonable adjustments to work expectations. So that way people can be successful in jobs. And we make these kinds of modifications when somebody has an obvious physical disability, but we need to think about that. And I think that that's true for autism, but also for all of mental health, and finding ways to support people in the workforce. So we also, on the education side, it's, again, thinking about what are the potential challenges, support for school applications. There in the US, I will say there's lots of learning enablement programs. A lot of programs are even developing autism-specific support programs for college students. And so those sort of engaging those right at the forefront so you can sort of hit the ground running. Finding, peer supports or coaching to help understand long-term goals and finances. And one of the things that I thought was really nice in this article I wanted to bring up was when thinking about education, a lot of times we talk about extended time on tests, but that's not always helpful because of people burning out, and that it may actually be better to have like a midpoint break where someone, because many people that have a diagnosis of ADHD, it's like you need to get up and sort of take a mental break and then come back. Just giving someone more time when they're sort of off task, that's not helpful. So it may be more helpful to get a break, like the clock stops, you go to the bathroom, you do something else, and then you come back and you start the clock again. So that was something I thought was really nice that they put into that. Anyway, additional modifications. This is getting more into the weeds of just different strategies, getting supports for personal assistance devices, if it's things that for people that may have challenges with speaking or communicating effectively, organizational supports. So getting supports around deadlines, goals, peer buddy support. These are more like, boots on the ground kinds of recommendations that providers should be making for adults. When we think about mental health, I'll just speak really quickly here to say that, obviously you should be working collaboratively with adults. You really want to talk about transition of care from pediatric to adult providers when you're talking about young adults. CBT, cognitive behavioral therapy, or cognitive remediation therapy, particularly around executive function, has been shown to be effective for youth with diagnosis of autism, of ADHD, both diagnoses. A really great program, which I can speak more to, is called Unstuck and on Target. There is an adult version that is currently being worked on. It's called Flexible Futures. And so you'll be seeing more research about that over the next 3 to 5 years as they finish the trial. But it's a very nice program for supporting executive function. And the group format may work better than individual is another thing that came up in consensus. And for pharmacological, I'm not a psychiatrist, so I can't speak intelligently about this. But, they did emphasize that start with non-pharmacological interventions first. And because many people on the spectrum tend to have unusual responses to medications, they tend to have a lower rate of success. And in the ADHD literature, that's what you see is that if they respond, they can respond quite well, but you have a higher chance of not responding to medication. And they talk a lot about low dosing and slowly ramping up, really paying attention to side effects for what I just mentioned. Consider alternative preparations for people who don't like swallowing pills. So just different kinds of compounds or different ways of making it liquid. And then also really having clear goals and outcomes so that are sort of agreed upon between the adult and the provider. And so you have a target, and that should be true for any treatment at this point. It should be really sort of skill focused, outcome focused, and you should know what you're working for. And the adult should know what they're working for and if they're getting there or not. And if they're not, then that they need to move on. I want to stop there. I want to make sure I leave a good 15 minutes for talk. So thank you. And I don't know if there's anything. Yeah, thanks, Wayne.
Yeah, plenty of questions. I would say more than a dozen or even more than that have asked about who should they go for, who should they seek out for a proper diagnosis of ASD, and are there any credentials they should be looking for? Really, a lot of people, I think, have that need to understand who they should see and how that evaluation should go.
That's a really great question, or questions, many of you. One, I will say it is really hard to find a qualified provider. For me, I think if you can, I would try to emphasize, particularly, and I think I saw some of the questions floating by. Some people have said nobody's gotten it right. I've been to a lot of people, and I think when that happens, I would really try to find somebody that is an autism expert. And in particular, I think I would say start with psychology first. Start with a psychologist and then psychiatry. Finding a good adult psychiatrist that knows about something that has a childhood onset is extremely, extremely difficult. So that's why I would want to emphasize, I think psychologists are really the better way to go because even I was trained working with children from the start. And when I talk with my counterparts who do lifespan work or who started with adulthood, they still have to understand autism. They still have to go back to childhood and they get that exposure somewhere in their training. And so I do emphasize that. In looking for credentials, I wish I could tell you that there was an autism certificate that people have to get as a mandated. They don't. But I would look for somebody that has done some form of training around autism. And so people will often acknowledge that. They will tell you if they do the ADOS, that will be up front. And I would look for that. Do they have to have research level reliability, which is what I have as part of our center at the Children's Hospital of Philadelphia? No, they don't have to have that. But you want to know that somebody has done some level of training with other people that would be considered autism experts. I think that's really important. I think from my experience, when I think about physicians, and I would say psychiatrists, psychologists, I would say, it's so independent. There are some I have met that have been fantastic, and I would trust their diagnostic opinion, and they're using the same measures that I use, the same psychiatric interview, and the same autism interview, and I would really trust what they're doing. And then there are others that don't, and they just say, well, I do a clinical interview. I just sort of talk about your past. And I feel like I really want to emphasize somebody that's going to use some of the tools I talked about, that is something that is part of what they do to inform what they understand, that they're going to go to other sources of information. If you have a spouse, if you have siblings, just to sort of really get a good handle on how have things looked over time. Because I think as adults, we get so much, we change what we do as we grow up because we learn how to protect ourselves. And we get different medications, and those medications have an impact on us. And then we act differently. And there is sort of a before and after. And so I just think that that's really important to, a psychiatrist can be really good about understanding the impact of those medications, but I think a psychologist is really helpful at pulling apart, that developmental history, looking at sort of current behaviors and pulling those things apart. So I would emphasize that, and I would emphasize that there are going to be people that will use some of the tools that I've talked about, whether it's an autism quotient or a social communication questionnaire, an ADOS, or other instruments that they can point to you and say, like, oh, there's research data behind this being effective. I would really emphasize that. So I'll stop there. I don't want to talk too much longer. I want more questions to be able to answer.
Well, I just want to go a little further with that. Are there any professional organizations for autism clinicians, or I just want to give people a lead about where to start looking?
Yeah. So I believe, and people have a lot of mixed emotions about Autism Speaks, and I will say I completely understand that. I think they do have lists of people that are autism providers on their website, so that would be one place to go. If you want to just get some other basic information, our center, the Center for Autism Research, we have something referred to as the Autism Roadmap. So the website is carautismroadmap.org. You can go there, and we've got things on there. If you have questions for yourself or for a family member, you can sort of, there's like a little wizard that steps you through things if you have concerns, and then provide some sort of resources of where to go next. I think that can be really helpful. If you happen to be somewhere in the Philadelphia metro area, we also have which I don't know how many of you are, but we also have a resources website there that then has a way to access different resources, including people that provide evaluations. So that is also available to people. But a lot of times I will tell people to start with, like, if you're near a major university, most of them that has a medical center, most of them will have an autism center. And if they aren't seeing adults, hopefully they have the ability to make recommendations. Right. Because of the lower base rate of autism compared to ADHD, 1.85% to the 10% that we see, they tend to stay within the medical home. A lot of people on spectrum will have medical conditions, GI problems, sleep problems. And so the medical centers tend to be home. So that would be the other recommendation, I would say, just for a starting point.
Mm-hmm. Yeah, that's a good tip. I like that. Are more females diagnosed as an adult with autism than males? Or are there problems with masking, et cetera, that affect a diagnosis for women?
Whoever's asking those questions, great questions. Yes, I think when I talk with my colleagues who are working with adults, it is very much true that females come to the diagnosis later, often after a lot of bad experiences. And so I would say, I do think that's the case. And masking, I think, is definitely an issue we hear a lot of females talking about. I have a colleague who's very interested in trying to understand that.
Maybe you could define that? Just define masking for people who don't understand.
Is when a person is trying to basically try to pass themselves off as not being on spectrum, trying to do things that they have watched others do that allows them to sort of not be identified, singled out, in a sense, hiding their autism traits or features. And so that there, I would say, we hear about that much more about females. So there's a very big debate in the research field about whether the low rate of autism diagnosis is because there's masking, and so we're not good at identifying, people who are females, who were born as females, identify as females at an early age, or there's also some research suggesting, and this is absolutely true, that genetically females are hardier than males. That is just a blanket statement that is absolutely true, because they have two X chromosomes and males do not. And so they are more hardy. And so that just the differences in terms of your genetic risk factor has to be so much higher to overcome that hardiness. That ends up, it's just harder for them to actually have those risk factors increase to that point. And there's a lot of research sort of trying to understand why there's that lower rate. Is there actually something to this? And they call it a female protective effect, versus this masking, camouflaging. And I think it's likely, my personal views, I think it's likely that both are true, that there is this protective factor, but that also, and because I see clinically that so many females are coming in, and I'm seeing teenage females who have seen adult females posting that, hey, I realized I'm 35, I'm on spectrum. I want you to know what my experience was like. And I'm seeing now 13 to 16, 17-year-olds seeing that, identifying with and saying, that's me, and then telling their parents, I want an autism evaluation. It is amazing. I mean, it is amazing to see it because people are taking control of their mental health and wanting answers and sort of crowdsourcing to understand by connecting with others. And I think I don't often sort of, applaud what happens on social media, but that to me has been such a huge plus that I've seen, particularly in the last year.
That's great. That's great. Yeah, several people have asked about that, about asking questions on social media, and has that increased the diagnosis rate? So,
yeah.
Is there a genetic component, you might have brought this up, forgive me, to autism?
There absolutely is a genetic component to autism. There's a genetic component to all mental health. And there's right now, what's really, I mean, there's been some studies where we combined data from millions of people across the globe. And the big take-home picture that we can say was that for things that are referred to as psychiatric or neurodevelopmental, autism and ADHD count as neurodevelopmental because it occurs across development, as opposed to, let's say, depression or anxiety that might have an onset, in teenage years or maybe earlier. What we've seen is that those neurodevelopmental psychiatric disorders have many more overlap in their genes, that they tend to be the same genes tend to be implicated. And then there's something else that they're intersecting with, either different combinations of genes with environment, that then push you towards one pathway or another. And that's very different from things like neurological disorders, like Parkinson's, Alzheimer's, and those disorders. That was a huge paper that came out of Science maybe 2 years ago. So yeah, there definitely is a genetic component to it. But it's not one gene. We're looking at like hundreds and hundreds of genes, each contributing a very small effect. But in combination together, they are sort of driving what's happening.
Right. That's very interesting. One last question, I guess several adults have asked, can they grow out of autism because they've learned to basically cope with the symptoms or traits? Several adults have asked that. They asked, is it more difficult to diagnose autism in adults because they've learned to cope or found their own coping mechanisms? So I would throw that out to you. Absolutely.
So there is some research on this. Yes, the short answer is yes. There about 10. Research suggests that about 10 or 20%, depending on how you define it, lose a diagnosis as they grow up, and it happens even in childhood, before reaching 18. So yes, I definitely believe that would be the case in adulthood. I definitely believe that would be the case, that it would make it harder to diagnose. I look at that as as a sign that we can move things, right? That the treatment and support in its life experience can help people be more independent. So I look at that as a positive, but I absolutely agree that it makes the clinicians' work much more difficult, particularly if you don't have people that can talk about, what it was like when that person was younger. Because the parents of that adult are no longer living. The siblings were 3 or 4 years old themselves, or 7 years old, and trying to talk about what their brother or sister was like at age 3 or 4 or 5. It was very hard to have any, objective measures of how often something was happening. So yes, I definitely think it adds to it. And for me, I really do emphasize that I'm not alone in this, and thinking like this is one of those signs that makes us feel like, for people that want to, sort of change, improve, or adapt certain skills, that like there's lots of reasons to believe that can happen. And there are a lot of adults that want that find like, hey, I don't like this, and so I want to change that skill. I want to improve that skill. And so that just gives me a lot of optimism that as we continue to work with autistic adults to learn more about their experience, learn more about what are the supports that are really going to be helpful, that we can do that, and that we can help them achieve their goals and objectives as adults. And then while also respecting adults and saying like, yeah, I do this differently, but I'm not bothered and it's not stopping me from living my life, and respecting that path as well.
Oh, that's an excellent way to end, an upbeat way. I think the hour is up. Thanks so much for being here. Really shared a lot of expertise and insights. It really was excellent. I learned a great deal.
Thanks.
So
thank you for having me.
Yeah, thank you for being here. And thanks to all of the attendees for joining us. And make sure you don't miss future Attitude webinars, ADHD expert articles, or important research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. So thanks everyone for being here and have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.
Determination comes in many forms, but always starts with a Dunkin' Run. So take your medium or larger coffee in one hand and grab a $1 donut in the other. No matter how you run, Dunkin' Run. A $1 donut with any medium or larger coffee. Excludes specialty donuts and fancies. Price and participation may vary. Limited time offer. Terms apply.